Welcome, and thank you for joining us for our presentation on primary care of migraine in pediatric patients. This is part of the American Headache Society First Contact Program, which was designed to help educate primary care providers about migraine disease. I am Dr. Jessica Gautreaux. I am a child neurologist and a headache specialist at Children's Hospital in New Orleans and Louisiana State University Health Sciences Center, and I'm joined this afternoon with Scott Turner, who will introduce himself as well.
So hi, I'm Scott Turner. I'm a nurse practitioner at the Hearsing School of Medicine at the University of Alabama at Birmingham. I worked in child neurology for the last 20 years and co-direct the headache program at the Children's Hospital of Alabama. My clinical interests are in reducing migraine disability in children and adolescents. And I'm a member of the task force that created the Pediatric Migraine Action Plan.
These are our disclosures. First, I want to give you guys a little bit of an expectation of what we're going to go through today. Our goal is really to empower primary care providers to provide really good care for a very common and very disabling disease, which is migraine. The layout of today's talk is that first, we're going to really help you understand how to recognize migraine, how to make a good diagnosis of migraine, and help your patients understand what migraine disease is and recognize its prevalence and disability. We want to talk about how to differentiate primary headache disorders like migraine from secondary headache disorders. We want to identify when patients might need more workup and when they might need involvement of subspecialists. And then finally, after that, we'll go through a good toolbox of ways to help manage this disease. Dr. Turner is going to take the first part of this presentation, and then we'll move into treatment at the end. And now I'll turn it over to Dr. Turner to start talking to us about diagnostics and recognizing migraine.
Thank you, Dr. Gautreaux. So this is an overview of the topics we'll be discussing. And I get the privilege of starting off the talk by asking what I think is the most important question of the entire talk, which is, what is migraine? And notice I didn't ask what is a migraine. I think if I did, you would say, well, it must be a terrible headache. But migraine itself is an inherited neurological disorder that's characterized by sensory, autonomic, vestibular, cognitive, and gastrointestinal symptoms. Attacks actually last longer and are more protracted, more complicated than previously thought. We know that migraine occurs over 4 different phases. There are premonitory symptoms, which involve dysregulation of the hypothalamus. And this produces symptoms such as fatigue, cognitive slowing, maybe mood irritability. People in this phase may find that they're drinking more fluids, eating certain foods or craving certain foods, yawning more frequently, stretching more frequently. These symptoms may occur anywhere from 2 hours to 2 days before the onset of the main event. So most of us know migraine as starting as a migraine aura, but as we just mentioned, it starts a bit earlier than that. About 15 to 30% of migraine sufferers experience an aura, so not everybody does. The aura is thought to be caused by a wave of cortical spreading depression, which is a depolarization of the nerve cells that spread across the surface of the brain. And when this happens, the nerve cells become hyperexcitable. And this is what is thought to be the cause of the aura. And it triggers the next phase of the attack, which is the headache phase. And in this phase, neuroinflammation appears to be the mediator causing the nerves in the meninges and throughout the brain to become more irritated. And these give you the symptoms that we classically associate with migraine, such as a pounding, throbbing headache, hypersensitivity to light or noise, sometimes the autonomic symptoms of flushing or pallor or diaphoresis. It may also cause, and often does in pediatric patients, significant GI disturbance, so nausea, vomiting, sometimes diarrhea. The postdrome is affectionately known by migraine sufferers as the headache hangover. And again, this corresponds to the resolution of the attack, perhaps the reabsorption of the inflammatory chemicals that got released along the way. But it may take a day or two for folks to recover completely from a migraine attack. So the pathophysiology of migraine is much more complex than we originally noted. We used to think of migraine as being primarily a vascular phenomenon, but now we know that it's much more complex than that. Again, the attack seems to start by dysregulation within the hypothalamus. The next phase seems to be associated with a wave of cortical spreading depression that causes hyperexcitability of the neurons in the cortex. Once excited, these nerves innervate the blood vessels of the dura and release chemicals into those blood vessels like substance P and CGRP, which cause vasodilatation and extravasation into the surrounding tissue, which further irritates the nerves. These irritated nerves then send the signals down into the brainstem, from which they propagate throughout the brain into other structures. So why is this a big deal? I think the biggest issue with migraine is how common and how disabling it is, even for pediatric patients. So how common is migraine in pediatric patients? Well, we know that worldwide, 1.1 billion people suffer from migraine. It affects 1 in 5 women, 1 in 16 men, and 1 in 11 children. How early does it start? Well, we don't know precisely, but we do know that infantile colic is associated with migraine. And this is based on some recent research by Dr. Amy Gelfand at the University of Colorado, San Francisco, who looked at interviewing children with migraine and found that they were 6.6 times more likely to have had infantile colic in their past history. So we know there's a relationship there. We don't know that infantile colic is a migraine, but we do know that it is closely related to the migraine phenomenon. Benign paroxysmal torticollis is a well-known episodic syndrome of young children, generally infants. These children develop a quick tilt of their head, which is often uncomfortable, and these attacks may be accompanied by autonomic features. They tend to resolve spontaneously within an hour or so. Benign paroxysmal vertigo is a bit more dramatic. These kids are usually toddlers. They may be playing one moment and then clinging for dear life to your leg or your torso, trying to endure the spinning sensation that is trying to throw them to the ground. Again, these attacks are self-limited and last a few minutes to a few hours. Perhaps the most dramatic of the episodic syndromes is cyclic vomiting syndrome. A typical child is a school-age child, around 7 or 8 years old, and these children will wake up in the middle of the night. They will often be pale, diaphoretic, and the key feature is almost incessant vomiting, prolific vomiting that can last hours or days. And these children often require medical treatment, either with antiemetic medications or may even require hospitalization to try to rehydrate them from dehydration. And finally, abdominal migraine. Basically, this is a migraine attack that doesn't produce a headache. Children with abdominal migraine experience abdominal pain described as a dull, aching sensation around the periumbilical region. Oftentimes, these attacks are associated with light and sound sensitivity, nausea, and vomiting, just as a typical migraine attack would. So when does migraine start, and how does it progress over time? Well, again, it may start as early as infancy, but when you ask adults with migraine, when did your headaches first start happening? Many of them will tell us that they started somewhere between 8 and 9 years old. So migraine is actually a condition of childhood, not just affecting adults. Prior to about age 6, boys and girls are roughly equally affected, with about 3% of young boys and 3% of young girls experiencing migraine. After that, when you get closer to puberty, there's a marked deviation or a marked change in frequency or prevalence between women and men, with girls and women having a considerably more prevalence of migraine versus the male population. And that persists throughout their life. So how prevalent is migraine compared to other conditions you often see in a pediatric practice? Well, we know that ADHD is present in 9.8% of children, and asthma is present in nearly 8% of children, with hay fever, frequent and recurring otitis all being rather frequently encountered in the pediatric practice. But did you realize that migraine, at its prevalence of 9.1%, is approximately equal to that of ADHD and asthma? Would you say, as a pediatrician, that you probably see about as many patients with migraine as you do with any of these other common conditions? Often not. And that's because migraine often goes under-recognized, underdiagnosed. And because of that, it often goes undertreated. And why is that a big problem? Well, it's because migraine is one of the most disabling conditions in the world. We know that it's the second most disabling condition across all age ranges, but it's the most disabling condition for women between the ages of 15 to 49. Why is it disabling to children? Well, unlike adults, they don't necessarily go to work, but school is the work of children. And so children with migraine miss considerably more school, have poor school performance and academic difficulties. They may miss out on sports and leisure time. and they have a lower quality of life than children with other chronic health conditions, and certainly a much lower quality of life than their headache-free peers. We know why it's important to make the diagnosis, but how do you make the diagnosis of migraine? First, we recommend looking at the bigger picture. You want to ask the child and their parent, when did this really begin? You want them to tell you not just about the current headaches or the bad headaches, but we want to know about all headaches. We want to know how they started and how they have changed over time. The most reassuring patterns consistent with migraine or tension type headache, the primary headache disorders, would be either acute recurring headaches. These are episodes that may happen maybe 2 or 3 times a month, up to 2 or 3 times a week. These headaches start and stop and are self-limited. They occur in stereotyped attacks, so one attack looks pretty similar to the other attack. If they start to come more and more frequently, you may develop chronic non-progressive pattern of headaches. So in this case, they may have some days that are good and some days that are bad, but overall, the trajectory of their headache problem has been pretty stable for several months. The chronic progressive pattern is among the more worrisome patterns of headache. This is a headache that started perhaps several weeks ago and appears to be getting worse and worse, maybe waking the child from sleep at night. It may be causing them to vomit first thing in the morning. This is the pattern that's quite concerning to us for things like brain tumor or perhaps pseudotumor cerebri or idiopathic intracranial hypertension, which are caused by increased pressure within the central nervous system. Perhaps the most dramatic pattern would be the thunderclap headache. It goes from 0 to 10 in 60 seconds or less. These headaches are associated with things like subarachnoid hemorrhage or ruptured aneurysm, and these are considered an emergent pattern of headache. The new daily persistent headache is a headache that starts one day and doesn't go away. It doesn't typically get worse and worse and worse like the chronic progressive headache, but it doesn't really get any better at all as time goes on. Now, while new daily persistent headache is technically a primary headache disorder, it can be a pattern that we see in other pathologies such as cerebrosinus venous thrombosis. So we talked about the need to distinguish primary from secondary headache. I think that the main mission that we have as healthcare providers and pediatricians are we want to make sure that the child doesn't have something serious causing the headaches. Thinking about these attacks as either primary headaches or secondary headaches gives us a framework for really understanding that concept. Secondary headaches are headaches that are caused by something other than the headache disorder. For example, infection is a very common cause of headaches that you frequently see in pediatric practice. Children often present with headaches associated with strep throat or with mononucleosis or with COVID-19. Minor head trauma, disorders of the head and neck, and other intracranial disorders like hydrocephalus could certainly give you secondary causes for headaches. Perhaps one of the more important but often overlooked is medication overuse headache, which is generally associated with headaches that are treated with a over-the-counter or prescription analgesic or triptan medication. But overuse of these medications may actually lead to worsening of the headache problem over time. Primary headaches are headaches that are caused by a headache disorder. In other words, the reason why a child with migraine has headaches is because they have migraine. Tension type headaches also present as primary headache disorders. Perhaps the most dramatic of the primary headache disorders are trigeminal autonomic cephalalgias. These headaches are associated with unilateral lacrimation or tearing of the eye, rhinorrhea or dripping of the nose, sometimes mydriasis or pupillary dilatation, sometimes drooping of the eyelid on the same side. These are always associated with unilateral headaches, which are actually a little bit less common in children than in adults. Remember that if someone has an atypical presentation of migraine or any red flags, we would recommend that they either be evaluated urgently by a headache specialist or possibly they would require an emergency room visit. Headaches are quite common. Migraine is very common. How do you identify kids with worrisome symptoms that need to be investigated more thoroughly? Well, we rely on a mnemonic called Snoopy, and Snoopy suggests that we screen for secondary causes for headache, including systemic symptoms such as fever, arthralgias, myalgias, night sweats, weight loss. Those don't typically come associated with migraine or tension type headaches. It really suggests that something else is going on. There is a population of patients that are worth careful scrutiny. And those include children who are immunosuppressed, those with cancer, those who are pregnant, and those with neurocutaneous conditions like neurofibromatosis. We spoke about the sudden severe headache or thunderclap pattern being one that needs to be investigated emergently. Occipital headaches are debatable. This comes from literature which suggests that children with brain tumor often report their headaches as being occipital in location. This is all based on retrospective data from the tumor registry. If you look at the issue prospectively, as Dr. Baer and colleagues have done recently, it turns out that children with brain tumors are more likely to have occipital headaches, but children with occipital headaches are no more likely than other children to have brain tumors. We spoke about the need to investigate a significant change in the headache pattern. Remember that children with migraine or tension type headaches, if they suddenly develop a thunderclap headache or a new daily persistent pattern of their headaches, we need to be alert for other causes of headache, such as meningitis, pseudotumor cerebri. Other things can come up in the midst of a migraine throughout the lifespan. So don't get tunnel vision when your migraine patient has a completely different set of symptoms. Here are some red flags and yellow flags to help remember when patients need to be evaluated urgently and when they need to be evaluated more closely, but not necessarily so urgently. Red flags include the thunderclap headache we spoke about, the worst headache of one's life. Again, that may be more important in kids that have a background history of headaches, alluding to the idea that if their headache changes markedly in its nature, we really need to investigate this closely. Children with a new onset of intractable vomiting, particularly in the middle of the night or on morning waking. Children with abnormal neurological exams, including a fundoscopic exam. The patient population we just spoke about on the last slide, those who are immunocompromised or have neurocutaneous conditions, may need to be evaluated more urgently. Children younger than 6 may need to be evaluated more urgently, and that's because children in this age range may have difficult time expressing what exactly they're experiencing during an attack. They may have difficulty understanding exactly what you're asking when you say, are you experiencing any light or sound sensitivity? Sometimes we have to rely more heavily on what the parents notice in terms of their behavior. Brain tumor is also more common in this population than in older children and adults. Therefore, it bears higher scrutiny. New daily persistent headache or a change in pattern, a side-locked headache, such as those seen with hemicrania continua or cluster headaches that are consistently present on waking from sleep, and those that are induced by position change or cough, strain, or Valsalva need to be investigated further. So, how do you recognize the children with migraine? Migraine is quite common, and some of these other things we just spoke about are relatively uncommon. So I think you can feel more confident about migraine diagnosis if you realize that migraine is a episodic syndrome in and of itself. Children with migraine attacks usually get a history of several attacks that are fairly stereotyped from one event to the next. Migraine in children and adolescents often is shorter than migraine in adults. And so while the ICHD-3 criteria for migraine in adults says that adults need to have headaches that last between 4 and 72 hours, children with migraine really only need to have headaches that last 2 to 72 hours. And remember, for both populations, this refers to untreated headaches. It's also important to know that in children and in adults, for that matter, we count the time they spent sleeping as time included in that headache duration. The location of the pain, the description of the pain, and the intensity of the pain are important to record and pay attention to, but they're not particularly helpful in differentiating migraine from other primary headache types. The presence of nausea and vomiting, presence of light and sound sensitivity, the aggravation of the headache by routine physical activity, those are much more sensitive and specific to picking up migraine in a child or adolescent. And remember, if people fit all of these criteria and don't appear to be having symptoms of some other condition, you can feel confident in your diagnosis of migraine. Children and adults with migraine may experience an aura. Most commonly in children and adolescents, this aura is a visual aura, but it could be a sensory aura or a motor aura. We used to think of an aura as a warning sign, but auras can actually occur before, during, or even after or in between headache attacks. It's also possible to have an aura without any headache and it still be a migraine. Aura symptoms typically start and progress over 5 to 10 minutes and generally last from 5 to 60 minutes. Remember that generalized blurry vision is common in migraine attacks and does not necessarily mean that child is having an aura. Which children need to be imaged, and what is the value of imaging in any given child? Well, the reason why many pediatricians and even headache specialists will image children is to provide parents, families, and ourselves sometimes reassurance against things like brain tumor. And while brain tumor is more common in the pediatric population, particularly in younger children, the incidence of brain tumor is not particularly high. Nevertheless, 1 in 10 children with brain tumor will present with headache as the primary feature. The problem is that imaging is not without its cost and is not without its risks. We know that CT scan of the brain exposes the child's developing brain to radiation, which may be problematic over time. An MRI of the brain is expensive and may expose a child to gadolinium if that's used. We know that gadolinium can accumulate in the brain, and we don't know precisely what the result of accumulated gadolinium is over time. We know that MRI may require general anesthesia or at least sedation to keep the child still enough to obtain an accurate picture. Perhaps most compelling is that any type of imaging in a child or adolescent may reveal an incidental finding. And so this is a finding that we need to report to the family, but may not be relevant to the cause of the headache itself. Often, if you tell a parent or a family that the child has a cyst in their pituitary gland or their pineal gland or retrocerebellum, the family begins to perseverate on the presence of the cyst, no matter how strongly you try to encourage them that the headache is not caused by the cyst itself. And sometimes this will require additional surveillance over time, which adds to the cost and anxiety for the family. Bottom line, there is no necessity to do neuroimaging in patients who meet the diagnostic criteria for migraine, have a normal neurological examination, do not have atypical features of migraine, and no red flags. The Choosing Wisely campaign is an effort to look at the benefit versus cost of any given intervention across a wide range of medical specialties. And the Choosing Wisely campaign has developed a guideline around imaging headache in children and adolescents. And basically what it says is don't perform neuroimaging in patients with stable headaches and meet criteria for migraine. If you're going to obtain an imaging study, they recommend obtaining an MRI of the brain rather than a CT due to the relative benefit over the risk of radiation. The ACR, or American College of Radiology, has a guideline that helps you to decide which study and whether to use gadolinium or contrast media. What scenarios seem to be the most likely to provide useful information in guiding your treatment plan going forward. So I'm going to turn the talk over to Dr. Gautreaux, who will talk more about how to treat migraines acutely and preventatively.
Thank you, Dr. Turner. So before we really launch into the discussion of management, I want to take one moment to pause and just really focus on how important all of the information that Dr. Turner just shared with us is. Patients really have to understand their diagnosis of migraine and that they have a disease state as the cause of their headaches before they can really buy in and become invested in a treatment plan. I can't tell you how many times patients come to my office as the subspecialist where they have a diagnosis of migraine and they are on a proper treatment plan, but they come to me and state that they're coming because no one knows why they keep having headaches. And I always pause right at that moment and let them know that their pediatrician or their primary care doctor did understand the cause of their headaches. And we talk about migraine disease at the very beginning of the visit. So really, to make progress with all these tools that we're going to give you for management, patients really have to be confident that you, as the treating physician, understand the cause of their headaches and that they don't need to continue on a journey of trying to understand the cause or the reason for their headaches. Headache as a symptom tends to be socially a complaint or something that people experience that can be alarming. It raises lots of red flags for people. So you have to be able to calm some of those concerns and make sure that people understand what's going on before you can really even start talking about treatments. The other thing to know about migraine treatment is that it is multifaceted. So treatment plans are designed with multiple parts, and it's really the combination of all of the parts that helps people have success with management of this disease and reach their goals. And it's important that patients understand that no one part is more important than the other part, that you really have to look at this all together and follow a comprehensive plan to ultimately get where you want to be with this disease. So in the next part of this talk, I'm going to take you through all of the components of a typical migraine treatment plan that we use in pediatrics. I'd like to start by talking about the lifestyle and behavioral changes that are a very important part of migraine management. Going back to the idea of making a diagnosis, when I talk to patients about the disease of migraine, I usually pause and give them a comparison to other chronic disease states, so diseases that you live with throughout your life, things like cardiovascular disease and diabetes. And I talk to patients about how management of those diseases frequently involve components of overall wellness that can impact those other diseases. And then I mentioned to them that migraine is very similar. Migraine as a disease appears to be sensitive to some external factors and some of our overall wellness and health. And so addressing those things that might impact migraine disease can help people be more successful in reaching their treatment goals. Now, when you start talking about lifestyle and behavioral changes, it's very important that you make sure, again, to frame that setting that the cause of the headaches is the disease. Because when you start to tell people that there are things they can change about their daily habits in their life, if you're not careful, they may feel that you're saying the cause of their headaches is maybe their sleep habits or their eating habits. And you don't want to have a blaming conversation when you talk about lifestyle modification. You really want patients to understand that you're empowering them to make changes that might impact their disease state. So to help patients remember what those interventions are that can be made on a daily basis to change their migraine disease, we use the mnemonic SMART. And SMART stands for sleep, meals and hydration, activity, relaxation, and triggers. We then break down each one of these letters of the mnemonic into specific goals that patients can have to help impact their migraine disease. Now, this is an often overlooked part of treating pediatric migraine, but it's very essential. And I think one of the reasons it's overlooked is because it takes time. It takes time to go through each one of these interventions and help patients understand specific goals for each one of these areas. But if you do it, it can really be helpful for your patients. I have had patients come in before who have gotten counseling. They're told to sleep more or drink more and eat more. But if they don't have a specific goal that's set for them, they may think increasing their hydration, for example, by 1 bottle of water is enough, when really they needed much more hydration than that. Or they may be getting 6 hours of sleep and think that getting 7 hours of sleep is reaching their sleep goal, when really they aren't. So when you talk to patients about these SMART habits, you have to be very specific. And sometimes it takes time to help them come up with behavioral changes and behavioral plans to meet some of these goals. To review the kind of overall recommendations for sleep, or wanting to counsel patients to get enough sleep for their age. We want to make sure that they're having consistent sleep schedules and ending napping when appropriate. And this gives you a chance as a physician to also screen for the sleep disorders that can impact migraine disease. So checking on snoring, looking for things like sleep apnea, looking for insomnia. For meals and hydration, we don't focus as much on specific foods, but we do talk to patients about eating a healthy diet, 3 meals a day, snacks when needed, and trying to eat whole, healthy foods as opposed to processed foods. We then again give specific goals for hydration based on the patient's age. And then also for our athletes, we try to give them specific hydration goals depending on their athletics as well. For activity, the American Academy of Pediatrics does have some recommendations for physical activity for children, but in regards to headache, we usually recommend that patients aim for at least 30 minutes of physical activity 3 to 5 days per week. And again, when you're talking to patients about activity, helping them come up with a plan to achieve that is important. If you have a patient who's very sedentary and you give them instructions to begin 30 minutes of activity 5 days a week, their ability to succeed in that might be limited, but if you give them a plan to work up to that, that can be very helpful for patients. Again, from a medical standpoint, at this point, you can screen for and address obesity, as obesity is known to contribute to migraine disease over time. The next one in the mnemonic is the R for relaxation. So we know that there is an interplay between mental health and migraine disease, and addressing that with things like biofeedback, mindfulness, deep breathing, yoga, can help to improve migraine disease over time. For you as a physician at this point, again, screening for things like depression and anxiety that might come into play, or in part to do when you're thinking about the R and the mnemonic as well. And then finally, some discussion of triggers. In migraine disease, the focus on triggers is starting to shift and change a little bit, but there are going to be patients who do feel and who have found through keeping logs and diaries that they have some very clear triggers. So having a conversation with them about their triggers and how to incorporate consideration of those triggers into their migraine disease is very important. Now, I want to pause a moment on that R in the SMART mnemonic, because whenever you start to talk about mental health, sometimes you might get some questions back from patients. So when you bring into the idea of relaxation or how mental health kind of interplays with migraine disease, it is important that you, again, go back to the idea that you understand they have migraine disease and that caring for and improving mental health is just one of the factors that might impact their migraine disease. You want to make sure that you're not expressing that you think because you're talking about mental health that their pain is not real or that pain is just in their head. But again, that improving mental health can also impact migraine disease. Biofeedback, cognitive behavioral therapy, and relaxation trainings are some of the modalities that are endorsed by the U.S. Headache Consortium guidelines and that have evidence for being effective at managing migraine at multiple different stages of life, including in children. We recognize that with the limitations on mental health in the U.S. and also from a standpoint of long waiting lists, insurance coverage, not all people will go and be able to get formal biofeedback or formal training in relaxation or formal cognitive behavioral therapy. And you yourself may not have training to be able to teach someone deep breathing techniques or mindfulness exercises, but there are resources out there where families can seek this training on their own. So here on the screen, we have 2 QR codes for 2 resources that we often refer patients to that we wanted to share with you today. So headachereliefguide.com is a site that was designed for adolescents. So the content on this website is very appropriate for our patient population. Not only does it have disease education, which we already talked about is incredibly important in managing this disease, but it teaches some of that relaxation and mindfulness practices. And then the American Migraine Foundation on the other side of the screen is another resource where patients can go and learn some exercises they can do on their own without having to seek out formal behavioral therapies. The next component of a typical migraine treatment plan is going to be the use of acute therapy. So this is the therapy that you use to treat the individual migraine attacks. So there are 2 models that are typically recognized for acute care. There's a stepwise model of care and the stratified model of acute care. In a stepwise model of care, patients are advised to usually start with a less specific medicine, such as an NSAID, and then if there's failure of that medicine, then they can start to escalate to more specific therapies. The stratified model of care says that patients should have options from things that are less specific all the way up to things that are more specific and sometimes combinations of different medications to treat attacks based on the severity of their attack. Many patients with migraine disease can tell pretty early on in a migraine attack if they're having a milder attack or a more severe attack. And we actually know that patient satisfaction is actually better if you use the stratified model of care. So helping patients come up with multiple different options that they can use to treat attacks based on the severity of attacks. And we use this idea of sort of a fire burning to help give a visual of what this means. So when the fire is small or a milder attack, that's when you kind of lend towards those more non-specific therapies, such as NSAIDs and other interventions. And then for an attack that is extremely severe or a bonfire, then you're probably using a combination of NSAIDs and other migraine-specific therapies. So the typical things we think about are NSAIDs, triptans, and dopamine antagonists, and any combination of those based on each individual patient. And it's important to think about the fact that all of migraine treatment has to be very individualized to each patient, and there's a lot of shared decision-making between the patients and the providers. And so coming up with that individual plan for patients based on the intensity of their headaches can take some time, but it's very useful to get a lot of buy-in and to get patients really on board with what to do for their attacks. We'll review a little bit from the AAN and AHS acute treatment guidelines for kids. The agents typically used in the NSAID category is going to be ibuprofen at a dose of 7.5 to 10 mg per kg. The triptans that have approval for use in kids are going to be the sumatriptan naproxen combination oral tablet, zolmitriptan in a nasal spray, sumatriptan in a nasal spray, rizatriptan as a melting tablet, and the oral tablet from almatriptan. And then we do sometimes use dopamine antagonists, as I mentioned, which tend to be one of prochlorperazine, promethazine, or metoclopramide. Of note, ondansetron can be helpful for the nausea associated with migraine, but not as much the headache or the head pain in a migraine attack. The dopamine antagonists that are mentioned on your screen here actually do have some evidence for treating the migraine attack as a whole, both nausea management and pain reduction. It's important when you're talking to patients about using one of these acute treatment options that you do review with them that early treatment that's appropriately dosed increases the likelihood of positive outcomes. So you want to make sure that patients feel empowered based on that scale of severity to go right to the highest dose that you recommend of their migraine treatment plan right when the headache starts. You don't want them to think they have to wait. You don't want them to think they have to try other things before they can treat an attack. They need to treat early with the most effective medicine for the type of attack that they're having. So how do we sort through some of those available items that are out there to choose the best options for our patients? So as I mentioned already, typically there's shared decision making here. So let's just go through the triptans, for example. The triptans there are multiple triptans with multiple formulations of each type of triptan. So when you're trying to choose which one, sometimes it's as simple as what does the FDA labeling say? Some insurance providers, for example, won't cover medications that don't have FDA labeling. So you're limited there for certain patients. Other times you can use a little bit more individual features of the migraine attacks to try to choose the best medication. So for example, rizatriptan and zolmitriptan come as a dissolving tablet. So for your kids or your patients who can't swallow pills yet, you may need to choose a dissolvable formulation. Some patients have a lot of GI upset and nausea and vomiting with their migraine attacks. So in those patients, sometimes you have to choose a nasal spray and avoid the GI tract completely to treat their migraine attacks. So again, a lot of times it's shared decision making. You're trying to choose what the patient prefers, also features of their individual attacks, maybe their individual insurance coverage and access to medications to help you find the best formulation for patients. It's important to note also that there are two triptans, frovatriptan and naratriptan, that both have longer half-lives. So those can sometimes be useful in patients who have headache recurrence. And also those two triptans with the longer half-life sometimes have a slower onset of action and tend to have fewer associated side effects. Now, sometimes other things you have to consider are the other medicines they're on. So on the chart, you'll see, for example, that rizatriptan dosing has to be adjusted in patients who are taking propranolol. Well, propranolol, as you guys might remember, is a commonly used preventive in the management of migraine. And so it wouldn't be unusual to have patients taking both of those, and then you may either have to adjust dosing or choose a different triptan. A couple of other tips for when you're prescribing triptans. It's always important to give proper counseling on how to use triptans. So there's a rule of two that applies to using triptans. So first, most triptans come with diagnosing instructions that say you can take a second dose 2 hours after the first dose if you haven't reached your treatment goals, but that you should not take more than 2 doses in 24 hours. Overall, we typically counsel patients to aim to use triptans 2 days per week or less to avoid the possibility of overuse of medication contributing to headache frequency. Another warning if you're going to prescribe triptans is that you are probably going to get some alerts back from pharmacies and payers about the combination of prescribing triptans with SSRIs and SNRIs and the possibility of serotonin syndrome. You will get these a lot, and to avoid alarm, I do want to let you guys know that there is an American Headache Society position statement saying that currently available evidence does not support that you need to limit the use of triptans in those patients who take SSRIs and SNRIs. So I prescribe those comfortably together, but I do get the notices across my desk at least once a week. So if you're going to start doing that regularly, you want to know how to address those notices when they come to you. Another important thing when prescribing triptans is to talk about potential side effects. People who are naive to triptans can be really alerted if they have some of the common side effects, especially in the first dose. So triptans can cause a tight feeling in the face, neck, or chest. People can feel flushed or tingly, and that can be alarming if it happens the first time you take a medicine because it may feel like an allergic reaction. Some people might even confuse it with something like anaphylaxis. So you do have to warn patients that this can happen. It's also important to talk about it because sometimes people won't bring it up, but this makes them uncomfortable enough that they start to avoid their triptan. And so you want to bring it to their attention that it could happen and that they should alert you if it's something that makes them not want to take their triptan because you want them to have an option they want to take right when an attack happens to end the attack. Other potential side effects of triptans include flu-like symptoms, fatigue, and myalgias. And then finally, we are treating a group of patients who overall in peds tend to be healthier than the adult population, but don't forget those cautions and contraindications that exist for the use of triptans. So in the adult population, it really is coronary artery disease and ischemic heart disease that is limiting for use of triptans, but don't forget that those conditions can exist in children too, and those would be reasons to not use triptans. If your patients have a history of TIA or stroke, you should avoid use of triptans. Uncontrolled hypertension, severe liver impairment, and then finally, some of the rare migraine subtypes, such as hemiplegic migraine, do still have contraindications on label to using triptans. We have developed a tool called the Migraine Action Plan or the Migraine Management Plan. You guys, as pediatric primary care providers, are probably very familiar with the tool, the Asthma Action Plan, which help patients and those people taking care of our patients, such as schools, school nurses, parents, to properly treat attacks based on the idea of red, yellow, green. So kind of that traffic light idea of green means go, yellow means slow or pause, and red means stop what you're doing. So the Migraine Action Plan takes that idea of green, yellow, and red and correlates it with pain. So when you're having a migraine attack, when you're in the green zone, you're still functioning. When you're in your yellow zone, you're starting to have some symptoms and it's really starting to slow you down and maybe interfere with function. But there are times where you might have red type of symptoms that really stop you in your tracks. On the left side of the document, you're able to fill in with specific treatment plans for each of those different categories of symptomatology, red, yellow, or green. It's a great way for patients to have a visual of what to do when they need to treat a migraine attack. And then also it gives you something that's very clear and concise to give to those people who are caring for the patient, for example, school nurses. It also allows you to be very customized. We've talked a lot about how migraine care has to be very individualized, and this gives you an easy tool where you can write out all of the individualized components of care for each patient. A few pearls for acute migraine management. When there's significant nausea and vomiting, you may have to combine your triptans with anti-nausea medication, or it may be best to just pursue non-oral routes of administration completely, like I mentioned earlier, nasal sprays or even injections. When patients tell you that a medication is not effective, it's always important to make sure that they're taking their medication early in their attack, that they're using the proper dose to treat their attack. And then finally, if those things are in place and are being done properly, then it might be time to move to something else in the treatment plan. So if they're on an NSAID, you might move to something that's more migraine specific. If they're already on a triptan, you might start to consider doing combination therapy with NSAIDs or dopamine antagonists, like we mentioned earlier. When patients have headache recurrence that happens very soon after treatment, again, this might push you into that idea of using combination therapy, so NSAIDs and dopamine antagonists, or moving into those triptans that I mentioned earlier that have those longer half-lives like naratriptan and brozatriptan. When patients tell you they are using medication at a high rate, this might be an indication to you to start a prevention and then also have a conversation with them about proper use of their acute treatment to avoid overuse. And then finally, if they're failing therapies, it may be time to bring in headache specialists. Next, I want to talk a little bit about the third component of a migraine treatment plan, which is the use of migraine preventives. So not all patients who have migraine we're going to require the introduction of a pharmacologic or an agent for prevention, but it is good to know and have some basic guidelines on when you might need to add a preventive layer of treatment to your migraine treatment plan. The AAN guideline recommends that you discuss prevention when patients are having 1 to 2 days per week of headache with moderate or worse disability. That is not always the only reason, though, that we might add a preventive. So sometimes we add preventives because migraine attacks are really starting to interfere with school attendance or activities. Sometimes it's just preference, especially since migraine is a disease that runs in families. Sometimes you have patients who you're seeing where the family is very well educated about the options that are out there for treatment, and they're really interested in adding a preventive. Other times, people are overusing medications. They're feeling like their acute medications are ineffective, or they don't tolerate acute treatments very well. And so they may not have that frequent of attacks, but when they do have them, you're at a loss of how to manage them very effectively or comfortably for the patient. So you want to try to decrease the number of attacks, despite that the number is not as high as you might use for that 1 to 2 days per week. Most children will benefit from the two parts of the treatment plan that we talked about already, which is behavioral and lifestyle change, plus maximizing acute treatment. But there's a large population of patients who will need that added layer of preventive therapy. Some of the options that are out there for preventive therapy include the use of both nutraceuticals and pharmaceuticals. So I'm going to start with the nutraceuticals first. Nutraceuticals are non-pharmaceutical therapies that are often used for prevention. I find in pediatrics, we often go to these medications, mostly because of the common thought that nutraceuticals have lower amounts of side effects, lower rates of adverse events, and are better tolerated. Most commonly, we talk about using riboflavin, another magnesium, CoQ10, or melatonin. It's probably riboflavin that has the most evidence for use in peds, but there is evidence for magnesium, CoQ10, and some for melatonin as well. When we're dosing those for riboflavin, we usually use between 50 to 200 milligrams twice a day. Magnesium, 9 mg per kg per day divided by BID. Coenzyme Q10, usually around 100 twice a day, or if their weight-based dosing is lower than that, you can use that. And then melatonin, up to 6 milligrams, but 0.3 mg per kg per day. It's important when you're talking to patients about using nutraceuticals that you don't act like they have no adverse events, because there are some known things they should watch out for. So, for example, if someone's going to take riboflavin, it can discolor the urine. Depending on which form of magnesium they use, you can get some GI side effects from that. We usually recommend magnesium oxide to decrease that, but it certainly doesn't mean that it can't happen. When patients are trying to choose which one they might want to use, again, some of that individualized and shared decision-making will come in. For example, coenzyme Q10 can be the most costly, so that might be one that families would prefer to save to try later. And then melatonin probably has conflicting evidence most often. If you look online, things such as Vertebr will come up as having evidence for migraine prevention, and certainly families can find this information and will ask you about it. But due to some concerns about liver toxicity from things that were available in past brands, Vertebr is no longer recommended because it's hard to be sure that patients won't be exposed to agents that can cause liver toxicity. When you look at pharmaceuticals, the ones that are most commonly talked about for use in pediatrics are going to be your anti-seizure medicines, so topiramate and valproate, antidepressant, amitriptyline, your antihypertensive or beta blocker, and propranolol, and then ciprofloxacin. Ciprofloxacin does not have a tremendous amount of evidence from a controlled trial standpoint, but clinically it's one that is used very frequently in pediatric migraines, specifically in younger children. So it is on the list. It's also nice that it comes in a liquid, and a lot of these other medications don't. So for young kids who need a preventive that comes in a liquid, ciprofloxacin can be really useful. Topiramate is typically dosed at about 2 mg per kg divided twice a day, but be aware of the potential reproductive risk and the need to supplement folic acid, and talk about contraceptive in patients who are of childbearing age. Amitriptyline is usually dosed around 1 mg per kg before bedtime. But again, this is an antidepressant and does have black box warning for suicidality that has to be discussed with patients if you're going to use that. Propranolol, 20 to 40 milligrams 3 times a day, but it is contraindicated in asthma, and so it's something to be aware of in this patient population that we're treating. And then finally, valproate, 40 milligrams per kg divided BID, carries a high risk of side effects, does have a reproductive risk, and requires the folic acid supplementation and discussions of contraception, as we mentioned with topiramate. Topiramate and amitriptyline have high or moderate confidence, and then propranolol and valproate have low levels of confidence when you look at the AAN and AHS guidelines. But again, clinically, these are agents that we use regularly. Now, no discussion of treatment of pediatric migraine would be complete without reviewing the childhood and adolescent migraine prevention study, which we all commonly refer to as the CHAMP study. This is a study I actually discuss fully with my patients so that they understand what we know about treating pediatric migraine from a rather big study. So the CHAMP study was designed to look at the efficacy of common preventive agents that we were using in adults at this time when applied to pediatric patients. So the group was divided into patients that were randomized to placebo, topiramate, or amitriptyline to see if either or both demonstrated significant improvement versus placebo in headache days or disability. This study was also designed where when patients began the study, they received disease education, They had maximization of their acute treatment, the two parts of a treatment plan that we already talked about. And then during the course of the study, they were meeting with a study nurse every 2 weeks, or a study coordinator, about their disease. So a lot of disease education went into this too. So it was a combination for every patient in the study of education and lifestyle modification, acute therapy, like we already discussed, and then some form of preventive, whether that be placebo or a pharmaceutical agent. The study was actually concluded early for futility as neither active medication was outperforming placebo. But with that said, a majority of the patients in this study were meeting the primary endpoint of greater than 50% reduction in headache days with this treatment design. Another thing that was learned is that the patients who were taking the pharmaceutical agents, topiramate or amitriptyline, did have a higher rate of adverse events than placebo. For the patients who improved in the study, they have now followed that cohort out for several years, and they have maintained the improvements that they got when they were enrolled in the CHAMP study. What we feel we learned from the CHAMP study, even though it was interrupted for futility, was actually that we know that majority of children with a good, multifaceted, multi-layered treatment plan for migraine management will have significant improvements, and that if they achieve that, they can maintain those results for years at this point. We have 3-year data on that. When you have a discussion with families about adding that layer of prevention, I always talk to them about what we know about the study and then help them make a choice between if they'd like to try something like topiramate or amitriptyline, or if they would like to try a nutraceutical first, and have some shared decision making on risk benefit and the actual evidence that we have out there, but reassuring them that we know that this kind of 3-step approach to treating migraine can be very effective. So when talking about adding a preventive, there's some really important tips that you should incorporate into your practice. So the very first thing is talking to patients, one, what we know about it, but then also setting appropriate expectations. You want them to know what your goals are when you add a preventive. First and foremost, preventives are not a cure for migraine disease. You are not going to ever completely eliminate attacks. Your goal is to decrease attack frequency and decrease patients' disability, and then sometimes even get improved response to acute therapies, but again, not cure the disease with a preventive. It's also important that you let them know that when they take a dose of preventive, it is not doing anything on that day to prevent a migraine attack. So if someone starts a preventive and the very first dose later that day, they have a migraine attack, they can be completely floored that they took their preventive and then had a migraine attack. So it's important to let them know that preventives take time to work, and that it's a long duration of time on a preventive therapy that seems to adjust the frequency of migraine attacks or change someone's disease state somewhat to where they have less attacks. But that doesn't happen immediately, and it doesn't happen each time you take a dose. So that way they know too, if they miss a dose, they're not to anticipate they're going to have a migraine attack that day. It's really that the steady use of this medication over time can help them reach a treatment goal. We typically tell them to anticipate 8 to 12 weeks before they will see the impact from being treated. And that's about 8 weeks at the full dose. So another important point of using a preventive is that if you're using especially one of the pharmaceutical agents for preventive, I already mentioned they have adverse events and side effects. So to mitigate that, you can start at a low dose and titrate it slowly, which can make the medications more tolerable. And when they do that, that's going to delay the duration of them seeing the impact from starting that preventive therapy. So they need to be counseled that it's going to be 2 months or 8 weeks from the time they reach that target dose that we expect to really start to see the impact on their headache disease. When you're choosing a preventive agent, remember that a lot of patients who have migraine might have other comorbidities. So they may have some insomnia or difficulty with sleep, for example. So when you choose your preventive agent, sometimes the thing that guides which preventive to choose is going to be what other things you can help with the same medication. So in someone who has that insomnia, maybe amitriptyline at bedtime is a good preventive agent for them because it might improve their sleep, but it might also impact their migraine disease. And then one of the most important points to make is letting patients know that preventive medication is not meant to be in place forever. I think for parents who are making the decision about whether to put their child on a daily medication for migraine or not, they are concerned that they might be committing their very young child to a lifetime of medication, which can be scary for some parents. So you need to let them know that this is not committing them to a lifetime of preventive for migraine disease, that we use preventives in short courses. So we typically treat for about 3 to 6 months with a preventive, and when we meet our treatment goals, we're able to wean off of that medication and have preserved benefits from that course of medication that we did. It's important to let them know at the very beginning that that's the expectation, that at some point we're going to take this medication away, and we actually expect for you to continue to do well even if we remove it, kind of going back into those appropriate expectations that we talked about at the beginning. If you do reach a point where you're going to refer out for a headache specialist appointment or involve a headache specialist, letting patients know what to expect can be very helpful. So letting them know that headache specialists sometimes can add novel therapeutic options for control of their disease that you can't do in a primary care office. So potentially enrolling in clinical trials and research studies for management of this disease, adding a layer of being able to do procedures for management of the disease, such as onabotulinum toxin injections or even nerve blocks. And then also possibly bringing in other therapy agents, such as the neuromodulation devices, which have approval for both acute and preventive treatment in migraine. And I want to pause a moment here on neuromodulation because we do have this on the slide specifically for headache specialists, but neuromodulation is really growing in popularity for use in adolescents and kids. It is non-medicinal, so a low amount of side effects, doesn't have risk from overuse. And to be quite honest, they're kind of cool because they're gadgets and they're kind of techie, and those are things that kids are already into. And especially for kids who don't want to take medication, the neuromodulation devices can be really attractive. Because of the fact that they have a low amount of side effect, it may be something that you do want to get comfortable having in your migraine treatment toolbox. And so I want to let you know that there is more information on the main First Contact website about neuromodulation devices if you'd like to learn a little more about that, because our talk today doesn't have time allotted to be able to go in depth on neuromodulation. Summary from treatment, again, is really honing in on creating an individualized, multifaceted treatment plan for each patient with migraine disease and helping them to understand their treatment goals and also recognize that all of the parts of their treatment plan are equally important and must be followed really to meet their ultimate goals for their disease. The last part of our talk, we're going to pause just to address kind of a common concern that comes up when you're talking about treating our patient population in pediatrics, namely adolescents, and that's going to be the use of hormones and contraception in patients who have migraine disease. The recommendations on the use of combined hormonal contraceptives are not actually uniform. The main point here is that we know that patients who have migraine with aura have an increased risk of stroke compared to the general population. The risk of stroke in our patient population is relatively small, but if you have migraine with aura, that's going to increase somewhat. And so then the concern comes that if you add something else that is known to increase stroke risk, namely estrogen, you're going to be even further escalating risk of stroke in young females with migraine with aura. The World Health Organization, ACOG, and most of the organizations that have weighed in on this still recommend that you avoid the use of combined hormonal contraceptives in females who have migraine with aura. But the International Headache Society has come out and said that low-dose estrogen actually may be prescribed in patients who have migraine with central visual aura. And I'll take you a little bit through why that trend is happening. First, let me talk a little bit about kind of the two places that contraception can come up in helping or in patients who live with migraine disease. And then we're going to go a little bit into that evidence on the stroke risk. So for patients who have migraine with aura that are trying to make a decision about contraception, your main goal is going to be to limit stroke risk. So you may counsel them on things like choosing non-hormonal IUDs, or if they're going to use a hormonal-based option, possibly considering progestin-only options. In patients who have migraine without aura, when you're talking about contraceptive options, you need to keep in mind that if you're going to use a hormonal agent, hormone fluctuation can actually bring on migraine attacks in some patients. So you want to decrease the risk of that hormone fluctuation in your contraceptive triggering migraine attacks for patients. So it's typically advised that you use monophasic, low-dose estrogen if they are going to use the contraceptive pill, and other considerations would be progestin-only contraceptives or the use of vaginal rings, which have a low dose of estrogen as well. If you see patients who have a change in their migraine symptoms, their headache pattern, or have the development of a new aura when they didn't have aura before, when they start an estrogen-based contraceptive option, you should stop that in patients who have migraine. So finally, looking a little bit about that ischemic stroke risk. Migraine with aura increases stroke risk in adults. The odds ratio is between 1.6 to 2.4. in this old studies, when you had migraine and you combine that migraine with aura with an estrogen containing contraceptive, your risk of stroke increased with an odds ratio of 7 to 8.7. Now, we know that stroke in pediatrics overall is rare, but we know that patients, even pediatric patients who have migraine, do have an increased risk of stroke, somewhere with an incidence rate of about 3.4. So when you look at those studies that talked about the use of estrogen with migraine with an odds ratio of 7 to 8.7, that data came from a period of time where most of the contraceptives out there were much higher in their estrogen dosing. And we know that now most combined hormonal contraceptives have much lower estrogen dose than was used when these studies were conducted. So I just wanted to put up here what we have to share for you is the odds ratio for ischemic stroke relative to those lower dose estrogen tablets that we have now. And if you look at non-estrogen based components, the odds ratio for ischemic stroke is not there, it's 1. And when you go up to the low dose estrogens, you only go up to 1.7. So it is increased, but it's not nearly as increased as when we were using those old, much higher dosed estrogen products where estrogen was at 50 micrograms and the odds ratio was approaching somewhere between 3 to 5. With what the International Headache Society is saying is that since lower dose estrogen products are available now that have a much lower risk of increasing your risk of stroke, that possibly can be used in patients who have simple aura. It's based on this information of the much higher stroke risk with the higher dose estrogen products. So to summarize our whole talk today, the main thing that we really need to be able to do for our patients who have this very common migraine disease is see a patient and recognize migraine disease when it's there and make sure that there aren't other causes or secondary causes of headaches. Once you've made that accurate diagnosis, you can really educate patients about this disease that they are probably going to live with throughout their life, and then help them come up with an individualized treatment plan that they can use acutely for attacks. They can think about day after day to kind of modify their disease state, and then to help come up with specific goals and whether or not you might need to add a layer of prevention. It's also important to not forget about those other tools that are out there for migraine disease management, namely behavioral therapies, use of nutraceuticals, medical devices, other items that you may not think of off the tip of your head that might be available to limit disability as well. And finally, I would like to draw your attention to the First Contact website in general. So First Contact was built as a comprehensive program to help educate those in primary care about the most up-to-date information in treatment, recognition, and our understanding of migraine disease. This website was designed to have information there for all types of learners. You can actually visit the website and kind of delve in more detail on a lot of the aspects that were discussed in our talk today. This website has things that are specific for adult, things that are specific for peds, and then just migraine in general. So we hope that you will visit this website to learn more and that we piqued your interest today. So thank you for joining us. I hope you found this talk today informative and useful for you as you go out there to take care of patients living with migraine disease.
Thank you, Dr. Gautreaux, and thank you for joining us on this talk. We hope that you found it useful, and we hope that you will continue your education in migraine therapy and treatment for children and adolescents with a very disabling disease.